The thing that I'm very interested in is that there's a whole new sorts of treatments, like bispecific T-cell engagers, just to pick one example, that are potentially very exciting. I mean, these are not yet proceeding through phase 3, but there's a whole lot of data around these sorts of things that are new. They're not just another way of targeting the AR pathway, and there's other ways of targeting radioisotopes as well. So there's going to be a whole lot of emerging data around things that I think are going to be transformational in the future, but not quite yet. So I think prostate cancer, the other thing that is still a sort of hotly debated topic is around PARP inhibitors. So my personal view is that the data looks the most compelling for patients with BRCA1 and BRCA2 and a very closely related package of very similar tumour mutations. But there are data that support unselected use. And for me, those data are currently not that strong. I think those sorts of things remain an unresolved question as to whether we need to test or not to give these drugs. My personal opinion is we probably will still need to test, driven by maybe unknown DNA damage repair mutations in some way, shape or form. But I think those sorts of things are very important. The other thing that's really very much of interest to me is the opposite end of the spectrum, how we diagnose people. So PSA-based screening remains controversial. There remains potentially ways of improving it, adding in MRI scans, adding in polygenic risk scores, adding in things like trying to find BRCA2 in particular carriers, because my colleague Ros Eels is showing data here showing that we should be screening those because they have an earlier presentation and a nastier disease biology. So I think there's a whole lot of stuff around diagnosis. Linked to that, there's a whole realm of stuff around inequalities of access. So patients from poorer backgrounds, from ethnic minority backgrounds, and particularly from black backgrounds, have poorer outcomes than white patients. Now, most of the screening trials were done in overwhelmingly white populations. So we don't really know how PSA screening performs if you actively go into areas with high rates of deprivation, high rates of ethnic diversity. And I think that's an area that requires a lot more work in the future, and there is work going on. I did a commission for The Lancet on prostate cancer future trends. And so one of the things that we highlighted in that is that the rates of prostate cancer globally are going to go up they're going to double, we project. And they're going to double because in middle-income countries in particular, they have a much younger median age than high-income countries. So if you look at a country like Nigeria, the median age is 15. Life expectancy in countries like Nigeria is going up rapidly because healthcare outcomes are improving. The healthcare coverage is a lot better now in sub-Saharan Africa and in countries like India, Brazil, and so on. And so life expectancy is going up, and the age structure means there's simply going to be more 60-year-olds, 70-year-olds in 10 years' time than there are now. They will get prostate cancer. You can't stop it happening. And so you're going to have to rapidly expand how you treat these people. It's not plausible to say we're going to double the number of urologists in Nigeria in 10 years. You simply can't do it. There's not enough at the moment. So you need to more than double. So the solution to that has to be that you have to train other people to manage prostate cancer. And so that's part in education. And partly, one of the things we highlight is that, for example, mobile phone coverage is very prevalent. So 95% of the population in Nigeria has a smartphone. Similar in India, similar in Brazil. And of course, the medical professionals have smartphones, so do the patients. So you've got a route that you can put patients' records on their own smartphone. That puts them in control. You can build in AI software that will say, right, well, for your sort of problem, this is the sort of treatment you need. And you can have the reciprocal software with the health professionals, because a lot of the treatments, chemotherapy, are simple to administer. You just have to actually give the right one. So I think there's a lot of scope for AI-assisted education, tailoring the education you receive as the healthcare professional to the patient in front of you. And I think we highlight that in the commission, that this has got to be a future direction of travel, because we're going to have to upskill people who currently have very low skill sets, because they're dealing with lots and lots of different things, and they're going to see an explosion of not just prostate cancer, but all of the other aging-related illnesses, heart disease, diabetes, lung disease, all these things that we see in the UK. you're going to be seeing more and more in Nigeria and India, whatever, because people are living longer.